Thank you. So I will just continue on what Hermann discussed and talk about another non-invasive treatment option for these patients with a chronic vestibular impairment. So we are talking about these patients that have chronic loss of both their vestibular sensors in their ears, and the main complaints that you can see again are walking difficulties, in particular if the other sensory modalities are not available to substitute for vestibular loss. So you see this wide characteristic and variable walking pattern and broad-based walking pattern that we refer to as sensory ataxia gait. And you see the impaired vestibular ocular reflex that then leads to these bumping movements when the patients walk. As Klaus and Hermann already discussed, the vestibular rehabilitation is the treatment of choice for these patients, but as you already mentioned, a lot of them are not satisfied with the outcome. So there might be these patients that have a complete loss and are then dedicated candidates for a vestibular implant, but a lot of these patients only suffer from partial loss of their function, meaning they can still possess vestibular cues. So here you can see, for instance, in experiments where these patients were asked to sense head rotations in the jaw plane. You can see them in red. They are still able to do that, but they suffer from logically increased thresholds to do that. And the consequence is that during their everyday activities, they will experience a situation that you can see here in the lower figure. So a lot of incoming cues during normal activities about the head motion are too low to be processed and to trigger perceptual or sensory motor reflex responses. And here is the idea for this alternative treatment approach. We could use some kind of neuromodulatory treatment to induce some kind of noise into the sensory system. And then the theory is that this low intensity noise and the 2-weak signal can interact in a way that the weak signal becomes amplified across the threshold to trigger then again perceptual or reflex responses, and that are required to be stable and to orient yourself. So importantly, this effect is critically dependent on the intensity of the noise. So too weak or too high noise intensities will either not work or even disturb the function, but there is an optimum in between where we expect the sensory function to improve. And we call this phenomenon stochastic resonance. It's a phenomenon that we know from all sensory modalities that we have in our bodies. And here's just an example from the visual system. So you can see here the university building here in Munich. When we fade out the image to a sub-threshold level and then increase the noise on every pixel, you will see there's an intermediate noise level where the image contours become visible again, but at too high noise intensities, you won't see anything again. Yeah. So that's the principle that we are looking for and want to use therapeutically. And as I said, it's has been demonstrated in all sensory modalities and is already therapeutically used in other cases. So you can enhance hearing by adding small amounts of auditory noise to the ear, and that's used in new generations of hearing aids. And you can also, by mechanical noise, improve tactile perception, and that has been used 20 years ago to develop vibrating insoles for patients with peripheral neuropathy. As I said, we will use that for the vestibular case, and we will use galvanic vestibular stimulation, so electrical stimulation of the inner ears to induce vestibular noise in the inner ear. You can see here a participant with 2 electrodes behind the ears. If you do the stimulation in a strong supra-threshold way, you will get a balance and postural response in the roll plane. We will use it in a really weak, noisy manner that is not perceived by the patient. And we know quite well from Kevin Cullen's work how we can do that. So we target stimulation intensities between 100 to 400 microamperes. So very low, the patients won't sense that. And that this is also a good placebo proof during the trials that I want to show you. So we started with effects on perception. And that's the modality that we can control the best. And so what we did, we used an established psychophysical paradigm where the patient sits in a motion platform, and then there are tiny movements in the role when the patient has to indicate whether he felt the movement, what direction. So, and then you can establish a threshold. We did it with sham, where there's actual stimulation and stochastic stimulation. And you can see in almost all patients, they were able to perceive weaker stimuli than without the stimulation. And there was a pattern that you will see in the future. And repeatedly, it was those patients that had a greater baseline impairment that benefited most from the treatment. And just to show you, so here we use this electrical galvanic stimulation. It's not depending on the modality. So you can also use a mechanical stimulus to induce the noise. Colleagues from Italy did that 2 years ago, and you see the same improvement at intermediate noise intensity. So quite general phenomenon that can be used therapeutically. So the next step was to look at balance reflexes. Can we also improve sensitivity there? We designed an analogous experiment where we could determine the threshold level where these patients actually responded to a balance threat. And again, the same picture. If we then simulate the patients versus shame, they are able to respond possibly to weaker threats than without the stimulation. And now, for the question, does this translate to behavioral relevant outcomes? So does standing and walking improve with this? So we first looked at standing, and what we did there was we just used the platform that Hermann already showed to you. So just a pause platform where you can record balance body sway. What we did in every participant was to, in a randomized fashion, induce different noise intensities. So we expect no behavioral response at very weak intensities, and we expect disturbance of balance at high intensities, and somewhere in between optimization and reduction of body balance weight. And we looked for this pattern, this bell-shaped pattern in participants, and then counted those participants, patients that showed this pattern. And this was about 2/3 of patients that actually responded in this manner consistently. And in half of the patients, this reduction of body balance weight reached clinically relevant magnitudes. And again, it was those patients that were more impaired at baseline that responded most to the treatment. So those patients with a lower gain individual head test and a greater baseline sway level. Then we looked at walking. I told you this very characteristic pattern of these patients walking is a highly variable stepping pattern, broad-based. And actually, it was those parameters that responded most during stimulation. So they walk more regular, and they do that primarily during slow walking. That's another quite consistent observation, that we have that these patients face challenges of balance when they walk slow, when they walk on uneven ground or in darkness. So that's the parameters that respond to the stimulation. And interestingly, these patients also failed that and reported that they are feeling more stable. So much on the balance side. So the question is, does it also, because we stay in the vestibular modality, so we could also expect treatment responses to other domains. So the question is, do we have treatment effects on destabilization? And there's so far not so much evidence for that. So the only evidence is 2 studies conducted in healthy individuals, and there they showed what we showed on the postural level. You can enhance the VOR by this stimulation. So they showed during stimulation that you can enhance the response that we typically report during clinical assessment if we are interested in ocular function, so the ocular vestibular evoked myogenic potentials. And they showed that the ocular counter role eye response is enhanced if you do the stimulation in healthy participants. So in principle, the reflex response, but we don't have yet behavioral outcomes whether this also reduces oscillopsia, and we are currently working on that in our laboratory. And there's another domain I was not mentioning yet, is that these patients also feel lost and have navigational problems, orientation problems. There's one study conducted in healthy participants that showed in principle navigational capacity can be increased even in healthy participants with this stimulation, but that was in an artificial virtual environment. And there's now quite recently a study where they used a more water-based task and could show that these animals benefit. These animals were bilateral vestibular loss and rats, and these animals benefit from the stimulation. So in terms of practical use of the stimulation, we asked, do we have to do this in an online fashion? As Hermann told you, when you switch off most of these devices, the effect is gone, and the same is here. So you can see we again went to the perceptual response. During stimulation, all these patients reduced their perceptual threshold. Then we did a prolonged stimulation, switched off the device, and immediately after switching off the device, the increased threshold popped up again. Yeah, so we have to use that in an online fashion. Is the take-home message from that. And then we asked, is there any benefit of combining this thing with established therapy like vestibular rehab? And again, the observation was negative. So these patients benefited from the rehab, irrespective of whether they were treated with the stimulation during the training or not. Yeah? So if we want to bring that into practical use, the take-home message is that we rather have to do that in a continuous mobile fashion. So we are aiming for a stimulator that is the size of a hearing aid behind the ears. And luckily, we have now an industry partner that supports us with this and builds a prototype for this. And with this, we want to go into everyday live evaluation, and we look at daily activity patterns and quality of life in these patients. Here is the first prototype of this stimulator, which we published recently. It's not as small as we want it to be, but at least it already agrees with strict safety requirements that we need for everyday use. You have a user interface where you can adapt the stimulation parameters for the individual need. And importantly, we only need this when the patient is active. So we have a motion sensor integrated into the stimulator. So only when the patient is active, the stimulation is switched on. Otherwise, it's switched off during the rest. And this allows us now with the current stimulator to continuously treat the patient with one battery for 24 hours. And to do that, we train the sensor to recognize what the patient is doing during everyday life. So we have an algorithm that can distinguish all the common activities, walking, sitting, climbing stairs, and so on during everyday activities. And it can also well be used to do data analysis. And I think that would be a good place to evaluate all our therapies with a motion sensor on the head. So what we then did, we just repeated with the stimulator all our experiments in the lab. And long story short, it works analogously as the big lab simulators on the perceptual level and on the postural level. One challenge that we have, so we looked at side effects of the stimulation, and what we saw was headache that the participants experienced after 2 hours of stimulation. And these headaches most probably did not occur due to the stimulation that's so weak that they don't feel it, but they had to wear a very tight headband to hold the electrodes on the side. And also without electrodes, this headband could cause them to get a headache up to 2 hours. So what we are currently working on with the industry partner is to really develop new geometries of electrodes that are practical for everyday use. So to summarize, we have this alternative and non-invasive treatment option that stays within the vestibular modality and aims to attenuate the perceptual imbalance deficits in these patients that have still some remaining function of vestibular processing requirement. We have initial evidence that it can also therapeutically work in other vestibular domains like gaze stabilization and spatial cognition. And we now have a first prototype of such a therapeutic device that we then want to evaluate in the live use. Thank you for your attention.